Hello, citizens of Internet. I am Dr. Ajit Virkud from Mumbai, India. I am a professor and ex-head of Department of Obstetrics and Gynecology. This is a channel that gives something extra. This podcast is inspired by the success of my textbook, which has been widely received by students and professionals alike. Each episode will delve into selected excerpts giving voice to my structured approach to topics in gynecology. Whether you're a student, a seasoned practitioner, or simply interested in the field of gynecology, I hope you will find these discussions both enlightening and engaging. Thank you for tuning in, and let's explore the world of gynecology together.
Have you ever just stopped and really thought about the human body?
Oh, all the time. I mean, it is an incredible machine, isn't it?
It really is, like a seriously impressive feat of engineering. And you know what I find especially fascinating?
What's that?
It's those systems that we don't always think about. The ones that are quietly doing their thing behind the scenes, so to speak.
Okay, I see what you mean, yeah. Kind of like the unsung heroes keeping everything running smoothly.
Exactly. And those unsung heroes are often just as crucial, maybe even more so, for our overall well-being. And that's what we are diving into today. We're shining a light on some of those vital components of the female anatomy that don't always get the attention they deserve.
Sounds like an important deep dive. I'm intrigued.
And to guide us through this exploration, we've got Professor Ajit Virkud's modern gynecology textbook. He really breaks down the intricacies of these structures.
Well, Professor Virkud's work is excellent. Very detailed and authoritative.
It is.
The goal is to really understand these structures inside and out, appreciate their unique characteristics, and grasp how they work together to make the magic happen, so to speak.
I like that. So are you ready to jump in?
Absolutely, let's do it.
We're talking about the uterus and the cervix.
Well, absolutely.
And I think, a lot of people think of them as one thing, the
Cervix uteri.
cervix uteri, right?
Mm-hmm.
But we're going to kind of take them apart,
Yeah.
look at each of them, see how they're different, how they work together,
Right.
and really give you a sense of how intricate they are. The uterus, even the name itself, kind of has a story, right? From the Greek sera,
Meaning womb.
meaning womb. And this is interesting. The ancient Egyptians and then later the Greeks, like Hippocrates and Plato,
Mm-hmm.
they thought that if a woman was having emotional or behavioral issues, it was because her uterus was wandering around her body.
Really? A wandering uterus.
A wandering uterus. Can you imagine?
That's a fascinating concept.
Yeah.
I mean, it speaks to how little was understood about the female body for so long.
Yeah.
And of course, it wasn't until much later, like the 18th century, that medical thinking started to shift
Right.
to the nervous system
Yeah.
as the root of such conditions.
Right.
And now, of course, we understand the uterus as this incredible organ, right? It's
Right.
responsible for menstruation, for carrying a pregnancy.
Yeah.
Really an amazing structure.
So where is this all happening?
Well, the uterus is located right in the center of the pelvic cavity.
Okay.
It sits between the bladder in front of it and the rectum behind.
Okay.
Now, in its non-pregnant state, it's got this kind of pear-shaped appearance.
Okay.
An inverted pear, technically called pyriform.
Okay.
If you want to get specific, the average dimensions are about 7.5 centimeters long,
Okay.
5 centimeters wide, and 2.5 centimeters thick,
Okay.
and weighs somewhere between 60 and 70 grams.
Got it.
It's connected to the cervix below, which then leads to the vagina.
Okay.
And then on the sides, you've got the fallopian tubes.
Okay.
And the ovaries are connected via the uterovarian ligaments.
Okay.
And the top part, called the fundus, is actually free.
Okay.
It's not attached to anything.
Interesting. And so how's it tilted? What's the normal position?
Well, typically it's antiflexed, meaning it's tilted forward towards the bladder.
Okay.
But sometimes it can be retroflexed, meaning it's tilted backwards towards the rectum.
Oh.
And this position can actually play a role in pelvic organ support.
So we've got this pear-shaped organ, certain position.
Right.
What's going on inside?
So it's not just an empty space.
Okay.
The uterus has a central cavity,
Mm-hmm.
and that's lined by the endometrium,
Oh.
which is this amazing glandular tissue, really important for menstruation and pregnancy.
Right.
And the wall itself has 3 layers. You've got the endometrium on the inside,
Okay.
then the myometrium,
Okay.
which is a thick layer of muscle
Okay.
responsible for those powerful contractions during labor.
Wow.
And then finally, the outermost layer is the serosa, or perimetrium,
Okay.
which is basically part of the peritoneum, the membrane that lines the abdominal cavity.
And it sounds like everything's connected, right?
It is, yeah.
So the uterine cavity opens into the fallopian tubes and into the vagina.
Correct.
You mentioned the fundus.
Yeah, the fundus is that dome-shaped top part of the uterus.
Okay.
Above where the fallopian tubes enter.
Okay.
Below the fundus, you've got the body of the uterus,
Okay.
which narrows down to the isthmus.
Okay.
And then that connects to the cervix.
Right, so everything flows.
It does.
And what about these pouches?
Oh, yes. The peritoneal folds create these pouches around the uterus.
Okay.
You've got the uterovesical pouch between the uterus and the bladder.
Okay.
And the rectuterine pouch, also known as the pouch of Douglas, between the uterus and the rectum.
Okay. Those sound important.
They are, clinically, because fluid can collect in them.
Okay, so we need to get this organ some blood, right?
Lots of blood, yeah.
How's the blood supply work?
Well, the uterus is special. It's got a dual blood supply,
Oh, wow.
which is unusual for a hollow organ.
Interesting.
It gets blood from the uterine arteries, which come off the internal iliac arteries,
Okay.
and also from the ovarian arteries, which come directly from the aorta.
Oh, wow. So 2 sources.
2 sources, and get this, they connect.
Really?
Yeah, it's called an anastomosis,
Okay.
and it happens in the broad ligament,
Okay.
which is this fold of peritoneum that goes from the uterus to the pelvic sidewalls.
Okay.
So you've got this incredible network of blood vessels
Wow.
with little branches going into every layer of the uterus, especially the endometrium.
So it's getting plenty of blood.
Oh, yeah, it needs it.
Yeah, for all those changes.
For menstruation, for pregnancy.
Okay, and the blood goes back out, right?
Yeah, it does. Yeah. Through a bunch of veins in the broad ligament that drain into the uterine veins.
Okay, makes sense. What about nerves?
Nerves. So the uterus is mainly controlled by the autonomic nervous system,
Okay.
which means it works without us having to think about it.
Right.
The sympathetic nerves come from the inferior hypogastric plexus,
Okay.
which gets signals from the thoracic and lumbar spine, T10 to L1.
Okay.
When these nerves are stimulated, the uterus contracts and the blood vessels constrict.
Interesting.
The parasympathetic nerves come from the pelvic splanchnic nerves,
Okay.
which come from the sacral spine, S2 to S4.
Okay.
These nerves do the opposite. They relax the uterus and dilate the blood vessels.
So a balance.
Exactly. And it's all constantly being adjusted by hormones.
Wow. Complex system.
It is.
What about the lymphatic system? Where does the fluid go?
The lymphatic system. So the uterus drains into a bunch of lymph nodes.
Okay.
You've got the iliac nodes, both internal and external.
Okay.
The sacral nodes, paraortic nodes along the aorta, and even some drainage to the inguinal nodes in the groin.
Okay, so all over.
Yeah, this system is really important for understanding how gynecological cancers might spread.
Right. So how does this organ even form in the first place?
Embryology. It's fascinating.
Yeah.
The uterus actually develops from 2 tubes called the parmesonephric ducts, or Mullerian ducts. Around the 8th week of development, the lower parts of these tubes start to fuse.
Okay.
But the fusion isn't complete.
Oh, interesting.
The middle parts form the uterus.
Okay.
The upper unfused parts become the fallopian tubes.
Okay.
And the lower fused end also contributes to the cervix and the upper vagina.
Wow.
The endometrium and myometrium, those functional layers, develop from the surrounding tissues.
Okay.
Knowing this is key to understanding congenital anomalies.
Right. It all makes sense when you see where it comes from.
It does.
Professor Virkud also talks about applied anatomy.
Right, how the structure relates to function and clinical implications.
Exactly. So what are some key takeaways there?
Well, one important thing is how the position of the uterus affects pelvic organ support.
Okay.
If the uterus is tilted backwards, retroverted, and retroflexed,
Okay.
it can increase the risk of pelvic organ prolapse.
So the position matters.
It does, yeah.
And there's this, I don't know, kind of poetic statement in the book.
Oh, yeah.
He calls the uterus a homely structure
I love that.
because it's where we all spend our first 9 months.
It's true.
It's a powerful thought.
Very powerful. Really emphasizes the essential role of the uterus.
Absolutely. So now on to the cervix.
Okay, now this is where it gets interesting.
Okay.
Because even though we often lump the cervix and uterus together,
Right. Cervixuary.
cervix uteri, yeah, the cervix is actually a distinct organ.
Okay.
It's got its own anatomy, physiology, histology, even pathologies.
Interesting.
So we need to treat it as a separate entity.
Okay, let's do it. So what's the basic anatomy like?
Well, the cervix is the lower part of what we call the uterus.
Okay.
It's more fibrous and muscular. And it's usually cylindrical or conical in shape.
Okay.
It's about 3 to 4 centimeters long and 2.5 centimeters in diameter.
Got it.
And it's held in place by some important ligaments, the cardinal ligaments and the uterosacral ligaments.
Okay.
Now, we can divide the cervix into two parts.
Okay.
The supravaginal portion,
Okay.
which is the upper half, continuous with the uterine body,
Mm-hmm.
and the portio vaginalis, also called the ectocervix.
Good.
It's the lower half that sticks out into the vagina.
Okay, so two distinct parts.
Two distinct parts, yeah.
Now, I know that the cervix can look different in different women.
You're right, the size and shape can vary.
Yeah. What influences that?
Well, age, parity, which is the number of pregnancies carried to term,
Okay.
and hormonal status,
Mm.
they all play a role.
So how does it look different?
For example, in women who have given birth vaginally, the cervix tends to be bulkier,
Okay.
and the external os, the opening into the vagina, is wider and more irregular,
Okay.
almost like a transverse slit. Whereas in women who haven't given birth, the external os is smaller and circular.
Interesting.
Doctors sometimes call it a pinpoint os.
Wow, so you can tell a lot just by looking.
You can. And then there's the endocervical canal,
Okay.
which is the passage that connects the uterine cavity to the vagina.
Okay, makes sense. So what about the tissues of the cervix itself?
Okay, so the cervix has a stroma, which is the connective tissue framework.
Okay.
It's got collagen, elastic fibers, smooth muscle cells, and all the blood vessels, lymphatics, and nerves.
Okay.
But unlike the uterus, which has distinct layers,
Yeah.
the cervix is defined by its unique epithelial lining.
Okay, tell me about that.
So the ectocervix, the part you can see during an exam,
Okay.
is covered by stratified squamous epithelium,
Okay.
same as the vagina.
Okay.
But the endocervical canal, the passage inside, is lined by columnar epithelium,
Okay.
which secretes mucus.
Interesting. So two different types of epithelium?
Two different types, yeah. And where they meet is called the squama-columnar junction. And under the epithelium is the basement membrane.
Okay.
And the junction between the epithelium and the stroma isn't always smooth.
Really?
Yeah, you can have these little projections called stromal papillae and reed pegs.
Okay, so kind of an uneven surface?
It can be, yeah.
Okay, so how does the cervix get its blood supply?
Well, just like the uterus, it comes from the internal iliac arteries,
Okay.
specifically the cervical branches of the uterine arteries,
Okay.
and they run along the sides of the cervix, kind of at the 3 and 9 o'clock positions.
Interesting. So what about nerves?
Nerves, so the cervix is also innervated by both the sympathetic and parasympathetic systems.
Okay, like the uterus.
Like the uterus, yeah.
Okay.
They come from the hypogastric plexus and the pelvic splanchnic nerves.
Okay.
But here's the key difference.
Okay.
The endocervical canal has way more sensory nerve endings than the ectocervix.
Really?
Yeah, and that has important clinical implications.
I can imagine. So what are they?
Well, because the ectocervix doesn't have many sensory nerves. A lot of procedures can be done there without anesthesia,
Oh, wow.
like biopsies, electrocoagulation, cryotherapy.
Okay.
But if you need to dilate the endocervical canal, which is full of nerves,
Right.
you definitely need anesthesia or at least pain relief.
That makes sense.
And because there are so many sympathetic and parasympathetic nerves in the endocervix,
Okay.
procedures like dilation and curettage
Okay.
can sometimes trigger a vasovagal reflex.
Oh, that doesn't sound good.
It can cause a drop in heart rate and blood pressure.
Okay, good to know. And the lymphatic drainage, does the cervix have its own system?
It does. It's a complex network.
Okay.
The lymph drains mainly to the pelvic lymph nodes,
Okay.
the external iliac, internal iliac, obturator, and common iliac nodes.
Okay.
And also to some visceral perimetrial nodes.
Okay.
And understanding this drainage is crucial for managing cervical cancer.
Right. It helps determine the stage and how to treat it.
Exactly.
So we've covered a lot of ground here.
We have.
And it's clear that while the uterus and cervix work together.
Right. We're distinct organs,
Absolutely.
each with its own structure and function.
Yes. The uterus with its ability to support a pregnancy, and the cervix with its role in protecting the upper reproductive tract and facilitating childbirth.
It's amazing how they're both designed for their specific roles.
It really is a testament to the complexity and elegance of the female body.
It is. It's truly remarkable. And so, on that note, I want to leave you, our listeners, with this thought.
Okay.
Think about how these two organs, the uterus and the cervix, while separate, work in harmony to support reproduction and overall female health.
Okay. Let's start with the fallopian tubes, also known as the oviducts. Picture these like as delicate hollow tubes sort of extending outward from the uterus.
Okay, I'm picturing them.
And they're tucked underneath this like protective sheet called the broad ligament.
Right, the broad ligament, essential for keeping everything in place.
Exactly. And Professor Virkud points out that they're usually about 10 to 12 centimeters long.
Yeah, that's about right.
But here's where it gets interesting. The outer end of each tube doesn't directly connect to the ovary.
Oh, that's right. It's more of a close encounter.
Yes. It flares out into this funnel-like shape with these finger-like projections called fimbriae.
Like little welcoming arms.
Exactly. And we'll come back to why that's so important when we talk about the journey of the egg.
Looking forward to that.
But first, did you know that the tubes aren't the same width all the way through? Professor Virkud explains that they're wider at the fimbriated end and gradually narrow as they get closer to the uterus.
Right. It's like a smoothly tapered pathway. And speaking of pathways, each tube can be divided into 4 distinct sections.
4 sections. Okay, break it down for me.
So first you have the infundibulum, that's the flared end with the fimbriae. And then there's the ampulla, the longest part, typically. And it has a thinner wall. That's usually where fertilization happens.
The big moment.
Indeed, the sperm meets the egg, and life begins.
Wow. Okay, so what's next on this journey through the tube?
Next up is the isthmus, a narrower section with a thicker wall. And lastly, the intramural segment, the shortest part, where the tube actually passes through the wall of the uterus to connect with the uterine cavity.
So it's a carefully designed route with each section playing a specific role.
It really is.
And Professor Virkud also mentions this structure called the mesosalpinx. What is that all about?
The mesosalpinx. Well, think of it as a fold of the broad ligament that specifically cradles the fallopian tubes.
Ah, so extra support.
Yeah, exactly. It's like a sling or a hammock holding them in place. But it's not just structural support. The mesosalpinx also carries the blood vessels and nerves that supply the tubes.
Oh, so it's like the supply line too.
Precisely, like the lifeline for the fallopian tubes.
And there's this distinction made between the mesenteric and anti-mesenteric borders. What's that all about?
Oh, good point. So imagine the tube hanging within this mesosalpinx fold. The mesenteric border is where the mesosalpinx directly attaches to the tube. The anti-mesenteric border is the opposite side, the free edge.
Okay, I think I'm getting the picture, but why is that difference important?
It becomes really important during surgery. We'll get into that a bit later.
Gotcha. Now let's zoom in, weigh in, and talk about what the inside of these tubes looks like.
Okay, microscope's out. So lining the inside of the fallopian tube, you have this layer of columnar epithelium, which is just a single layer of tall, slender cells.
Okay, cells, got it.
But here's the cool part. You've got 2 main types of cells in this lining. Secretory cells, which produce a nourishing fluid that helps the egg along, and ciliated cells, which have these tiny hair-like projections called cilia.
Cilia, okay. What do those do?
These cilia are amazing. They actually beat in a coordinated wave-like motion, gently sweeping the egg toward the uterus.
So it's like a little current inside the tube, helping the egg along.
Exactly. And get this, the ratio of these cell types actually changes throughout the menstrual cycle, all thanks to hormones.
Wow, it's amazing how everything is so interconnected.
It is, but there's more. Underneath the epithelium, you have the lamina propria, a layer of connective tissue for support.
Okay, so kind of like the tube's foundation.
Yes, exactly. And then surrounding all that are 2 layers of smooth muscle. These muscle layers are arranged in a spiral, which helps with peristalsis.
Peristalsis, remind me what that is again.
Oh, it's those rhythmic contractions that, squeeze the tube and help propel the egg along.
So it's a 2-pronged approach, the cilia creating a current and the muscles contracting. Pretty sophisticated for such a tiny structure.
Right. It's a remarkable system. But none of this would work without a good blood supply, right?
True. So how does the blood get to these busy tubes?
Well, they actually have a dual blood supply, which is kind of like a backup system. The part of the tube closest to the ovary gets its blood mainly from the ovarian artery. The part closer to the uterus is supplied by branches of the uterine artery. And these arteries form connections, so if one pathway gets blocked, there's still a way for blood to get through.
Smart design. And where does all that blood go after it's done its job?
Well, the veins pretty much follow the same path as the arteries, eventually draining into the ovarian and uterine veins. As for the lymph, it mainly goes to these lymph nodes near the aorta and in the pelvis. But some of it also travels along the round ligament, which can end up in the lymph nodes in the groin.
Okay, so it's a pretty complex drainage system, too.
It is, and of course, we can't forget about the nerves.
Right, the nervous system. What's its role in all of this?
So the fallopian tubes get signals from both the sympathetic and parasympathetic nerves. These nerves help control things like muscle contractions and other functions within the tube.
So they're like the puppet masters, making sure everything is moving and functioning as it should.
Precisely.
Okay, so to sum it all up, the fallopian tubes have one main job, right? to help the egg and sperm meet and get that fertilized egg safely to the uterus.
Exactly. They're the matchmakers and the transportation system all rolled into one.
And Professor Virkud mentions some really interesting clinical implications of all this anatomical detail, like, for example, during surgery.
Oh, absolutely. Knowing the ins and outs of the fallopian tubes is crucial for surgeons. For instance, if there's an ectopic pregnancy, where the fertilized egg implants outside the uterus, usually in the tube.
Oh, right, ectopic pregnancies. Those can be dangerous.
They can be. And in those cases, surgeons often have to do a laparoscopic procedure to remove the ectopic pregnancy. And knowing where those major blood vessels are is crucial to avoid excessive bleeding.
That makes sense. So they use their knowledge of the anatomy to plan the safest approach.
Exactly. They usually make the incisions along the antimesenteric border, where there are fewer major blood vessels.
That's fascinating. And Professor Virkud also points out that the isthmus, the narrowest part of the tube, is often the site of rupture in ectopic pregnancies.
Unfortunately, yes. As the pregnancy grows in that confined space, it can put too much pressure on the tube and cause it to rupture.
A stark reminder of just how important this anatomical knowledge can be.
Absolutely.
All right, let's move on to the next stop on our tour, the vagina.
Okay, the vagina. A truly remarkable structure.
It is. So tell me, what can you tell us about this essential part of the female anatomy?
Well, the vagina is a distensible, meaning it can stretch, fibromuscular tube. And it's lined with this special type of epithelium that doesn't have keratin.
Okay, no keratin. What does that mean?
Keratin is a tough protein found in things like skin and nails. So the lining of the vagina is actually quite delicate.
Makes sense. And I remember learning about the hymen.
Ah, yes,
Hmm.
the hymen. In individuals who haven't had sexual intercourse, the opening of the vagina might be partially covered by the hymen, which is just a thin fold of mucous membrane.
Right, right. And Professor Virkud points out that the vagina isn't positioned straight up and down.
Oh, you're right. It's actually angled. So like if a woman is standing, the lower third of the vagina is more or less vertical, but then the upper two-thirds tilt backward at about a 120-degree angle.
Interesting. So it's not a straight shot.
Nope, not at all. And speaking of angles, the cervix, which is the lower part of the uterus, actually protrudes into the upper vagina.
Oh, I see.
And that creates these little spaces around the cervix called fornices.
Fornices, okay. And those are important because...
Well, they're clinically significant, especially the posterior fornix, which is the deepest one. It's actually right next to this pouch called the pouch of Douglas, which is a space between the rectum and the uterus.
Got it. So these fornices aren't just random spaces, they have clinical relevance.
Right. They can be important landmarks during exams or procedures.
Now let's talk about the walls of the vagina. What are they made of?
Professor Virkud breaks it down into 4 distinct layers. Starting from the inside, you have that non-keratinized, stratified squamous epithelium we talked about.
Right, the delicate lining.
Yes. It acts as a barrier against abrasion and infection. And it's kept lubricated by mucus from the cervix. Important to note that the vagina itself doesn't have any glands that produce lubrication.
So the lubrication comes from the cervix.
Exactly. Next up, we have the lamina propria, a layer of connective tissue that has these little finger-like projections that extend into the epithelium. It also has a lot of blood vessels.
Okay, so support and blood supply. What's next?
Then we have the fibromuscular layer, which is mostly smooth muscle. This layer helps the vagina contract and relax.
Interesting. And outermost layer.
The adventitia, a fibrous layer that gives the vagina strength and keeps it attached to the surrounding structures.
So kind of like the anchor.
Exactly. That's what keeps everything securely in place.
Now, we often hear about the rugae, those ridges or folds inside the vagina. What's their purpose?
The rugae are amazing. They're like the wrinkles that allow the vagina to stretch.
Stretch.
Yeah, like during childbirth or sexual intercourse.
Ah, that makes sense.
They dramatically increase the surface area of the vaginal walls. And their prominence actually changes depending on estrogen levels. So during puberty and pregnancy, when estrogen is high, the rugae are more prominent.
And when estrogen levels drop, like after menopause,
They become less prominent.
makes sense. And I think a lot of people imagine the vagina as a simple cylindrical tube.
Oh, it's definitely more complex than that.
What's the actual shape?
If you were to look at a cross-section of the vagina, it actually has more of an H shape. It's kind of like an H lying on its side.
An H. That's interesting.
Yeah, it's all because of the way the surrounding organs and structures press on it.
Okay, so it's shaped by its surroundings.
Yeah.
What about the lymphatic system? How does that work in the vagina?
So the lymphatic drainage of the vagina is pretty interesting. It's kind of divided into 3 sections.
3 sections, okay.
The top part drains to the external iliac lymph nodes. The middle drains to the internal iliac nodes, and the bottom part drains to the superficial inguinal nodes, which are up in the groin.
Wow, so a multi-level drainage system.
It is.
Yeah.
And it's important to understand the system because it can affect how things like infections or even cancer cells might spread.
Makes sense. Now, let's talk about sensation. What can you tell us about the nerves on the vagina?
Okay, so nerves. The main nerve supply to the vagina comes from the uterovaginal plexus.
The uterovaginal plexus.
Yeah, it's also called Frankenhauser's ganglion. It's part of the autonomic nervous system. And then the lower part of the vagina also gets signals from the pudendal nerve.
Okay, two different sources of nerve supply.
Right. These nerves help control the muscles in the vaginal wall and the blood vessels. But here's the interesting part.
What's that?
Most of the vagina doesn't actually have a lot of specialized sensory receptors.
Really?
Yeah. So it's not as sensitive to touch as you might think.
Interesting.
But the very bottom part, the distal 1/5, that area is much more sensitive to pain and touch because it gets nerve signals from the deep perineal nerve, which is a branch of the pudendal nerve.
Ah, okay. So that explains why some areas are more sensitive than others.
Exactly.
And what about the blood supply to the vagina?
Oh, it's got a great blood supply coming from several different arteries. A branch of the uterine artery, the vaginal branch of the internal iliac artery, and branches of the pudendal artery. And the veins basically follow the same paths, eventually draining into the internal iliac vein.
So it's a well-vascularized area.
It is. But this is something surgeons have to be really mindful of.
Why is that?
Well, because those major blood vessels run in the adventitia, the outermost layer of the vaginal wall. So if there's a deep cut that goes through the muscle layer, it can cause serious bleeding.
Oh, I see. So they have to be very careful to avoid those major vessels.
They do.
Professor Virkud also talks about the structures surrounding the vagina.
Right, the anatomical neighbors.
Exactly. So what's the vagina's relationship with its surrounding structures?
Well, in front, you've got the urethra, the bladder, and the lower parts of the ureters. Behind it, there's the perineal body, the rectum, and higher up, the pouch of Douglas. And on the sides, you have the muscles of the pelvic diaphragm and those major blood vessels we talked about.
So it's nestled in there among some pretty important structures.
It is. And that's why it's so important to understand these relationships. Because what affects one structure can often affect its neighbors.
It's all connected.
Exactly. And then there are these specific landmarks inside the vagina itself that doctors use to guide them.
Oh, interesting. Like internal signposts.
Exactly. Like on the front wall, there's this ridge called the urethral carina, which is formed by the urethra. And higher up, the bladder creates a wider bulge called the anterior column.
Okay, I'm following you.
And in the upper part of the vagina, the ureters, those tubes that carry urine from the kidneys to the bladder, they pass pretty close to the vaginal wall.
Okay, so knowing where those are is important.
Absolutely. And on the back wall, the rectum creates a bulge called the posterior column. And of course, up top, there's the pouch of Douglas we talked about earlier.
So doctors use these landmarks to avoid injuring nearby structures during procedures, right?
Exactly. They're like a roadmap for navigating this delicate area.
Amazing. So the vagina is more than just a passageway. It's a complex structure with a lot going on.
It really is.
And speaking of complex, let's talk about its functions. What are the vagina's main roles?
So the vagina has three primary functions. It's the organ for sexual intercourse. It serves as the birth canal during childbirth, and it's the route for menstrual flow to exit the body.
3 essential roles, all related to reproduction and women's health.
Exactly.
Now, before we move on to the ovaries, are there any other important clinical considerations regarding the vagina that Professor Virkud mentions?
He does highlight a few key points, like the posterior fornix, that space we talked about near the cervix. It actually acts as a temporary reservoir for semen after ejaculation.
Oh, wow. I didn't know that.
Yeah, it gives the sperm a chance to, hang out and prepare for their journey to the egg.
That's amazing.
And another thing is vulvovaginal atrophy, which can happen after menopause.
What happens then?
Basically, the vaginal tissues get thinner, and the rugae flatten out, leading to dryness and painful intercourse.
Sounds uncomfortable.
It can be, unfortunately. And then there's the issue of vaginal prolapse.
Prolapse.
Yeah, that's when the walls of the vagina weaken and can even start to bulge out of the vaginal opening.
Oh, wow.
It's often a result of childbirth, and it can cause a lot of discomfort and even affect bladder control.
So those supporting structures we talked about, they're really important.
Absolutely. They play a crucial role in keeping everything in place.
Okay, well, I think we've covered the vagina pretty thoroughly. What do you say we move on to the ovaries, our final stop for today?
Sounds good.
So tell me, what can you tell us about these remarkable endocrine glands?
All right, the ovaries. They're like the dynamic duo of the female reproductive system.
Dynamic duo. I like that.
So picture this. They're these almond-shaped organs hanging out on the sidewalls of the pelvis.
Okay, got it. Almond-shaped.
Right. And they sit in this little dip called the fossa of Waldeyer.
The fossa of what now?
Waldeyer. It's formed by the angle between the external iliac vein and the ureter. It's an important landmark for surgeons.
Okay, so it's like their little home base.
Exactly. And in a woman who's still menstruating, each ovary is usually about 3.5 by 2 by 1.5 centimeters.
That's not very big.
No, not huge. And they get even smaller after menopause, shrinking down to about 2 by 1 by 0.5 centimeters.
So they're these little powerhouses, but how do they stay put?
They have a pretty intricate system of attachments. They're connected to the uterus by the ovarian ligament. It's actually a continuation of the round ligament, which runs through the inguinal canal and ends up in the labia majora.
Wow, so it's like this continuous tract from the ovary all the way to the external genitalia.
Pretty cool, right?
It is.
They're connected to the back of the broad ligament by a fold called the mesovarium, and to the pelvic sidewall by the infundibulopelvic ligament, which is also sometimes called the suspensory ligament of the ovary.
Wow, so like anchored on all sides.
Exactly. These attachments provide support and also act as pathways for the blood vessels and nerves that supply the ovaries.
Okay, that makes sense. Now, what about the inside of an ovary? What's going on in there?
Well, if you were to look at a slice of an ovary under a microscope, you'd see three main zones. The outermost layer is the surface epithelium.
Okay, so another lining.
Kind of, but it's not just a passive covering. Underneath that, you have the tunica albuginea, a tougher layer of connective tissue.
So support structure.
Exactly. But here's the key difference between the ovaries and the testes in men. The tunica albuginea in the ovaries isn't a complete impenetrable capsule.
Oh, that's interesting. Why not?
Because every month during ovulation, a part of this layer has to break open to let the egg out.
Ah, so it's like a door that opens and closes.
Exactly. Professor Virkud calls it a window opening. Very poetic, right?
I like that. So what's going on beneath this tunica albuginea?
That's where the action is. That's the cortex, where you find all those ovarian follicles in various stages of development.
You're right. The follicles, those are the structures that contain the eggs, right?
Exactly. And at puberty, each ovary has something like 60,000 to 80,000 of these primary follicles. But only around 400 of them will actually mature and release an egg during a woman's lifetime.
Wow, that's a pretty select few. And what's filling the spaces between the follicles?
That's the stroma, which is made up of connective tissue and various types of cells. It's kind of like the scaffolding that holds everything together.
And the innermost zone.
The medulla. That's where you find a lot of blood vessels, lymph vessels, nerves, and some other specialized cells, including Leydig-like cells, which can actually produce androgens.
Androgens, those are male hormones, right?
They are. But women produce small amounts of androgens too. They play a role in things like libido and energy levels.
Wow, so the ovaries are involved in more than just estrogen and progesterone.
Definitely. They're multi-talented.
Now, how about the blood supply to the ovaries? Where does that come from?
Well, they get their blood from the ovarian arteries, which branch off directly from the aorta.
Directly from the aorta?
Yep, they're VIPs.
Yeah.
But they also get a little extra blood flow from the uterine arteries, just in case.
So like a backup system.
Exactly. And the veins pretty much follow the same paths, but there's a little quirk. The left ovarian vein drains into the left renal vein, but the right ovarian vein drains directly into the inferior vena cava.
Huh, that's an interesting asymmetry.
It is, and it can be clinically relevant in certain conditions.
Now, how are the ovaries wired up? What about the nerves?
Well, they get both sympathetic and parasympathetic nerves from the ovarian and uterine plexuses. These nerves reach the ovaries through the suspensory ligament along with the blood vessels.
So it's like a bundled package deal?
Pretty much.
Okay, so we've talked about the structure, the blood supply, the nerves. Let's recap the ovaries' main functions. What are they responsible for?
They have two primary jobs. First, they produce the oocytes, which are the female gametes, or eggs.
Okay, the eggs check.
And second, they produce the female sex hormones, estrogen and progesterone.
Right, those hormones that regulate so much in a woman's body.
Exactly. And their production is controlled by hormones from the pituitary gland, luteinizing hormone, LH, and follicle-stimulating hormone, FSH.
So it's a complex hormonal dance.
It is, and it all starts right there in the ovaries.
Professor Virkud also delves into some interesting clinical aspects of the ovaries. What are some of the key takeaways there?
There are a few really important things to keep in mind. First, The surface epithelium of the ovary, that outermost layer, it's thought to be where most ovarian cancers originate.
Oh, that's good to know.
And then remember how we talked about how the tunic albuginea in the ovaries isn't a complete hard capsule?
Yes, the window opening.
Exactly. Well, that actually helps protect the ovaries during certain infections. Like if someone gets mumps, the ovaries can swell up without getting damaged, unlike the testes in men, which have a much tighter covering and can be damaged by the swelling.
That makes sense. So it's actually a protective mechanism.
It is. And of course, we can't forget about ovulation, that monthly release of an egg. Because the follicle ruptures through the surface of the ovary, it makes the ovaries more susceptible to infections that travel up from the lower reproductive tract.
Ah, so that's how pelvic inflammatory disease can affect the ovaries.
Exactly. It can lead to these nasty tubo-ovarian abscesses, which can be quite serious.
Wow, it's amazing how these anatomical details can have such significant clinical consequences.
It is. It really highlights the importance of understanding the anatomy.
Well, I think we've covered a lot of ground today. We've taken a deep dive into the vagina, fallopian tubes, and ovaries. And thanks to Professor Virkud's insights, we've explored their structure, function, and clinical relevance.
It's been a fascinating journey.
It has, and I hope our listeners have gained a deeper appreciation for the complexity and beauty of the female reproductive system.
I hope so too. It's an amazing system that deserves all the attention and care we can give it.
Absolutely. And for all our listeners out there, I'll leave you with this thought.
Ooh, a final thought. I love it.
Thinking about all the intricacies we've discussed today, how does this detailed knowledge of female anatomy empower us to better understand and advocate for our own health and well-being? It's a question I encourage you to ponder as you continue your own explorations of the human body and its remarkable capabilities.
Well said.